Today, we're going to talk about chapter 60, which is the fetal neural axis, which is a really interesting chapter. Again, your embryology, I'm not going to go over that too much today, but I would suggest that you read it in your book. So the spinal cord and vertebral column extend the length of the body. After the first trimester, the posterior portion of the body grows beyond the vertebral column. So yes, we have a tail at first and spinal cord, and the growth of the spinal cord lags behind the growth of the vertebral column. At birth, the spinal cord terminates at level third lumbar, and by adulthood, it's at the second lumbar vertebrae. Neural function begins at 6 weeks gestation, and it commences with the primitive reflex movements at level of face and neck. By 12 weeks, sensitivity has spread across the surface of the body, except at the back and top of the head. And the fetus begins to have defined movements and periods of activity and inactivity by 4th month. So around 8 weeks gestation, you'll see them wiggling their little legs and arms, and you'll see them jumping all around by 12 weeks. Between the 4th and 5th month, the fetus can grip objects like the umbilical cord or their feet. They love to do both of those, and is capable of weak respiratory movements. At 6 months, the fetus displays sucking reflex. So you'll see him dreaming and sucking in there, which is super cute. And about 28 weeks, there's changes in brave wave patterns. So many of the congenital malformations of the CNS result from the incomplete closure of the neural tube, with a wide range of defects that may affect the spine or brain. And so these occur early on in the pregnancy when the spine is developing. So this most common neural tube defect, because when you think of neural tube defects, you'd probably think that the most common would be spina bifida, but that is not the case. The most common neural tube defect is anencephaly. And I can attest to this because I have seen a lot of anencephaly, but I have not seen as much spina bifida. So I definitely do think, just from my population that I've scanned over the years, that anencephaly is more common. It's also known as aprocephaly and atelencephaly, but most of the time we just say anencephaly. Overall incidence is approximately 1 in 1,000 pregnancies, and the prevalence is 4 in 1 females over males, and 6 in 1 prevalence of Caucasian over African American. So it's more common in female fetuses and Caucasian fetuses. And the significant recurrent risk is 2% to 3% if the woman has had a history of a open neural tube defect. So if they've had a history of anencephaly or spina bifida, they have a higher chance of having it again. So what is it? It's caused by a failure of closure of neural tube at the cranial end, and it results in absent cranial vault, complete or partial absence of the forebrain, presence of brainstem, midbrain, skull, and facial structures. So basically, they don't have a large portion of their brain. They do have the brainstem, but the most of the cranial vault and the brain is absent. There's just a little bit of remnant brain. Up to 50% of cases end in fetal demise, and if they don't end in fetal demise, the remainder die at birth or shortly after, because there's no brain. There's just no way for the baby to know how to breathe or just live. It's really a sad condition. It really, really is. The prenatal diagnosis often made with sonography following referral for high maternal serum alpha fetoproteins. Where I've seen it, though, mostly is a patient is excited and comes in at 20 weeks scan to see what the baby is, the gender, not thinking that there could be potentially something wrong. And then when we start scanning, you definitely see that there isn't a brain. So there's multiple causes: Michael-Gruber syndrome, some chromosomal abnormalities like trisomy 13 and 18. If a mom has diabetes, environmental and dietary factors. And I always say one of the things I want everybody to do is, if they are planning on getting pregnant or at the reproductive age, make sure you're taking your prenatal vitamins, because folic acid helps with these central nervous system disorders. Um, and it decreases the risk of that. And so always taking your prenatal for the folic acid. So a lack of folic acid could be a reason. Environmental, I've heard that getting overheated in the first trimester could cause one of these disorders. And of course, amniotic band syndrome, if there is a band on um, the brain, it could have caused this earlier on in the development. So these are what it looks like, kind of, and I got better pictures, but these are the ones out of your book. And what you'll see is you'll see the orbits of the eyes. They'll look abnormally spaced. Now, do you guys remember what abnormally spaced eyes look like, or called, or hypertelorism? Kind of looks like frog-like, and it's probably because there's no cranial vault kind of holding everything in. And then you'll just see a flat area here where you would see the rounded skull. This is what it looks like post-mortem. Here's a couple other pictures. So it's just like you're just not seeing, like, the whole brain and skull is cut off. Here's a couple more of my images here. So the absence of the cranium. Here's a little bit of brain, but you can see this is the face. So the frog-like appearance of the eyes. But it's really easy to diagnose, just because it's such a dramatic kind of sonographic features. It just pops out to you. Anybody can kind of tell that there's definitely something not right. They may not know exactly what it is, but you can definitely tell that it is not normal. So other sono findings that occur with anencephaly are polyhydramnios, spina bifida, cleft lip and palate, hydronephrosis, diaphragmatic hernia, cardiac defects, and falcial GI defects, and talipes. So yeah, club feet occurs with this. Polyhydramnios occurs with this. So there's a lot of other things that can occur with this, or it can be an isolated finding. So that's anencephaly. Next on your list is acrania. And I have seen every single one of these this year, which is just crazy. Each one that we're going to talk about, I've seen over the year. It's a lethal anomaly, and it's where there's still a brain, but there's no cranial bones. Now, this occurs early on in the first trimester. By the time that we scan the baby, which would be about 18 to 20 weeks, it could look like anencephaly, just because it started out as acrania, started out with a brain but no skull, but turned into what it looks like anencephaly just because it was exposed to amniotic fluid so much, and kind of the brain is slowly degenerated from the amniotic fluid. So by the time you scan, it might appear to be anencephaly. And there's really no way that you can tell the difference. Let's see. Identification of additional findings such as long bone fractures help to distinguish these disorders from acrania. So if they have like osteogenesis imperfecta, hypophosphatasia, which we'll talk about in our skeletal dysplasia, there could be, it could kind of look like acrania. Again, you don't need to know that for this chapter though. So this is what it's going to look like. You're going to see a head, and you're going to see a brain, but you're not going to see the skull that is keeping everything in. So it's just going to be free floating brain. There's another image. Again, a very shocking sonographic finding. I think there's a couple more images. Usually acrania is caught in the first trimester, because by, again, the time 18 to 20 weeks, the brain has been degenerated due to the amniotic fluid. It may be associated with all those other things too: spinal defects, cleft lip, palate, club feet, cardiac defects, and phallocyl amniotic band syndrome. And that's one thing you're going to notice throughout all of these that I talk about. The same things are associated with them. Cephalocele is our next one, and it's a neural tube defect in which the meninges alone or the meninges in the brain herniate through a defect in the calvarium, usually in the posterior portion of the head. So there's a defect through the skull. So brain or brain and meninges can kind of escape through the skull. Then Salafel is termed used to describe the herniation of meninges and brain. So a cephalocele is just the general term for this. If it includes brain, the more specific term would be encephalocele. Cranial meningioceles describes herniations of the meninges only. Most of the time, what we see is some brain that is involved with this. And cephaloceles occur at a rate of 1 to 3 in 10,000 live births. So it's very rare. However, I have seen it this year. Usually involves the occipital bone, but like we talked about in the facial chapter, sometimes you can have an anterior cephalocele where it is occurring in the front. And in that case, that would spread the eyes out, which would be hypertelorism. So this is what it looks like. So you're going to have a defect in the posterior portion of the brain. And this is going to include meninges and also brain, or it could just meninges. Most of the time, it doesn't affect the brain too. Now, the prognosis varies on these based on the size, location, involvement. Like that was a very large one, so I don't think the prognosis is very good on that baby. The presence of brain and the defect indicates poor prognosis, so you have a lower chance of survival when there's brain involved. But if there's just a meningiocele, the baby has like a 60% chance of being normal mentation, so normal IQ. Sonographic appearance depends on, why do I do that? So they're classified according to the size of the lesion. The occipital cephaloceles occur when defect lies between the lambdoid suture and the foramen magna, which that's what you're gonna mostly see when you see these. The anterior cephaloceles lie between the anterior aspect of the ethmoid bone. You don't need to know this at this point. You just need to know that it's most common on the posterior side, but they can be anterior frontal. They can be anywhere in the brain, but most common posterior. And you need to know the sono features. So the extracranial mass, which may be fluid filled or contains solid components. So if it's solid components, that means there's brain. That term is called encephalocele. If it's just fluid filled, it's more meninges. It's a cranium meningiocele. The better prognosis is going to be when it's just fluid filled. When it contains brain, it's a poorer prognosis. Then it's a bony defect in the skull. They may also, well, they probably will have ventriculomegaly, so the lateral ventricles will be dilated. Do you remember what that is? The cutoff is we want it less than 10 millimeters, the lateral ventricle. So if it's greater than 10 millimeters, it's considered ventriculomegaly. Another sono finding is polyhydramnios. Now, if you're following this trend, you can pretty much say anytime that there's a central nervous system defect, the baby is going to have polyhydramnios. So you always can remember that. They're going to have more fluid, not less. Coexisting anomalies include microcephaly, agenesis of corpus callosum, facial clefts, spina bifida, cardiac anomalies, and genital anomalies. They could be confused with the cystic hygroma, but the difference is there's going to be a cranial defect with a cephalocele, and there's not going to be a cranial defect with a cystic hygroma. So this is some images that I found So this is a smaller one, cephalocele, because it's just anechoic, so it's just probably a little fluid filled. So this baby probably would have a pretty good prognosis. This has some brain involved and looks larger, so that's probably a more poor prognosis on that one. And this one also looks like there's some hypoechoic contents within the brain, so this is probably also encephalocele. Our next thing that we're going to talk about is spina bifida, and this is something that you guys have probably heard about in your life. And it is just a general term for a wide range of vertebral defects that result from the failure of the neural tube to close. The meninges and neural elements may protrude through the defect, and the defect may occur anywhere along the vertebral column, but most commonly along the lumbar and sacral regions. So what I want you to know is it's most common around the lumbar and sacral regions. The term spina bifida means there is a cleft or opening in the spine. Sometimes when it's covered with skin or hair, and it's called spina bifida occulta, which it's associated with normal spinal cord and nerves. So here we go. So when there's a little hair right here, but it's still intact, there might be just a little bit of an opening of the spine there. This is going to be just spina bifida occulta. So those kids do fine. This is a meningeocele, so just the meninges is protruding from the spine. This is a meningeomyelocele because this in C, because the meninges and the spinal cord are protruding through the spinal defect. D is the most serious form because there's not even really a membranous sac. There's just an open spinal cord. So these babies have the most poor prognosis because that amniotic fluid is able to, touch the spinal cord, and we know what amniotic fluid does to the brain. So probably with the same thing when it is also like exposed to the fluid. So the terms I want you to know for this are when the defect involves only the protrusion of the meninges, it's called a meningeocele. But a meningeomyelocele is more common where the meninges and the neural elements protrude through the defect. So that's more of C here. B is a meningeocele, C is a meningeomyelocele. So you need to know those two terms. If the defect is very large and severe, it's this term here, rachis. I've never been able to say it. I've been doing this for 5 or 6 years or 7. I don't even know, and I can't say it, but it's this D. It's a very severe form of spina bifida. It's associated with a varying degree of neurological impairment, minor anesthesia, paresis, or death. If it's not severe, a lot of these babies still do pretty good, but they might not be able to walk, or their bladder might be involved. Fortunately now, if we find this pretty early, they can do surgery, fetal surgery on some of these babies to help with the prognosis. Another thing that I really want you to know are our little fruits that are associated with spina bifida. And what I mean by that is there's different changes in the brain that give the appearance of different fruits, and that can help us really find a spina, like if there is a defect before we even look at the spine. So I usually am, if I see a normal brain, I'm pretty sure that they're not going to have a spinal defect, because there's multiple things that happen to the brain when there is a spinal defect. The cerebellum is pushed down and changes shape, giving it a banana appearance. This leads to the obliteration of the cisterna magna, which I'll show you. So you won't see a cisterna magna, a little cystic space behind the cerebellum. And there's also caudal displacement of the cranial structures that causes scalloping of the frontal bones, which causes a lemon shape. So the fetal head will look like a lemon, the cerebellum will look like a banana, and this will lead to obliteration of the cisterna magna. So those three points are very important. So here is an image right here on the top left-hand corner of well, let's look at the normal too. Let's go to the bottom. And you see that the cerebellum here is peanut shaped in the bottom left-hand quarter. That is a normal cerebellum. To the right of it is the cisterna magna, that cystic space that hits the skull. This is normal. We want to see this. When there is a spine, oh, and look at the circle of the skull. It looks very nice. When there is spina bifida, the cerebellum is pushed backwards, causing a banana shape. You can't see the cystic space anymore, the cisterna magna, so there's obliteration of that. And there's scalloping of the frontal bones, so you're going to see more of a lemon-shaped appearance of the bones, frontal bones. Here's another image of the lemon-shaped bones and the banana-shaped cerebellum, and no cisterna magna. Management of this includes serial ultrasound examinations to monitor progression and extent of the ventriculomegaly and to follow fetal growth. Fetuses are delivered early for ventricular shunting by cesarean section to preserve motor function. And surgical repair of the defects in utero. Risk incurred with procedure include premature delivery, maternal morbidity, and fetal mortality. However, there are good surgical, have been good outcomes from surgery doing the, and I have a video, I'll post it on our module of fetus having surgery, and it's pretty interesting. Again, the prognosis of the infant varies greatly according to the type, size, and location of the defect. The name I cannot pronounce, the rackees, I just need to look it up. I don't even know. The rackee, I'll call it the rackee, is invariably lethal and has the worst prognosis. Surgical closure of the defect performed to preserve existing neurological function. The sonographic examination of the fetal spine should include methodical survey of spine in sagittal and transverse planes, and the normal fetal spine should demonstrate posterior ossification centers completing spinal circle. What does that mean? Well, I took some pictures of it for you later. The meningeal myelocele, here is a defect in the posterior aspect of the spine. Here is an opening of the spine here. Okay, so these are my images. You can see that there's a protruding. Here's one coming off the spine. So these are sagittal images of the spine. So you would try to get a really good sagittal image. You want to see the spine closed, but if you see a protruding sac, this is going to be spina bifida. You note that these are all in the lumbar sacral region, which is most common. These are also probably meningomyelocele because any kind of hypoechoic content within the sac means that there's neural elements in it. When I say spleen of the vertebrae, what I'm talking about is in your top left upper hand corner of this slide, you can see that there's the 3 ossification points of the spine. This would be a transverse image. So we cut baby and like we're slicing baby, like baby's a loaf of bread. We're taking slices of the baby. So we're looking down at the baby in a transverse position. And so the spine is on top. You can see kind of looks like a little triangle. You can see the posterior ossifications. They're connecting, almost making a triangle or a circle. When there's spina bifida, you're not going to see that anymore. In the top right-hand corner, you see that the spinal posterior ossification sites have split and are protruding out. There's a neural tube outside. Here's some other images in transverse view. This in your lower right-hand corner, A is showing a sagittal view of the defect. B is showing the transverse view of the defect. You want to take both. I always want you to evaluate the spine in both sagittal and transverse views because you could potentially miss something in just one view. And so it's always good to take two views. The other thing that I always want you to do is make sure that you can get the spine on top. So the baby laying face down, evaluating this spine anterior closest to the skin. And this will make sure that the baby is not hiding a defect by lying on its back. After the spinal defect is identified, document the level and extent of the defect. Where is it at? So these look like they're in the lumbar region. The presence or absence of neural elements. Looks like there's some hypoechoic content. So yes, I would say there's a neural tube. And did we look at the brain? Oh, yes, we did. And there's banana-shaped cerebellum and lemon-shaped skull. So yes, this confirms that this is a meningeal myelocele. These are your associated cranial findings that I want you to know. Flattening of the frontal bones, the lemon-shaped, obliteration of the cisterna magna, the banana-shaped cerebellum, and ventriculomegaly, so a lateral ventricle measuring greater than 10 millimeters. Here is ventriculomegaly here. You can see the choroid plexus are looking like they're just kind of floating in there. That's a sign for you to know that those lateral ventricles are probably dilated without even measuring them. Sono associated findings, cleft feet, cephaloceles, cleft lip, palate, same things as all the other ones. Spina bifida has been associated with multiple syndromes and chromosomal anomalies, including trisomy 18, and also fetuses that have been exposed to some things like valproic acid. Maternal diabetes, maternal obesity, hyperthermia, folic acid deficiency are also associated with spina bifida. A family history of spina bifida is a significant risk factor too. So our next thing is Dandy-Walker malformation. The Dandy-Walker malformation is a defect that may have varying degrees of severity. Again, something that I've seen in the last month, actually. And it manifests with agenesis or hyperplasia of cerebellar vermis with resulting dilatation of the fourth ventricle, enlargement of the posterior fossa. So what that means is that Dandy-Walker malformation, let's look at it. I want to show a picture of it really quick. I would say in just general terms, when I think of Dandy-Walker malformation, I think of it just as a splayed cerebellum. There's some chromosomal anomalies that are associated with it, or it could just be on its own. And the prognosis does depend on the presence or absence of associated anomalies and how the degree of hypoplasia of the cerebellar vermis depends on the IQ. So these are your sonographic findings. You'll have a very large cisterna magna instead of a very small, like in spina bifida. You'll have the splitting of the cerebellar hemispheres as a result of complete or partial agenesis of the cerebellar vermis. Enlarged cisterna magna and ventriculomegaly. Here's some images from your books. So this is the cerebellum, and you're missing the vermis, which is in the middle. So they're splaying of those hemispheres. Here's another image here of the splaying of the cerebellum and a large lateral ventricle. Here's my images. Aren't they clear? This is a normal head with a normal cerebellum, because I always like to have you guys be able to look at what's normal and then compare it with what's not. So on the left hand side is a normal cerebellum. On the right hand side, you can see the splaying at the middle. So you're going to have a very large cisterna magna, and then you're going to have that gap in between the cerebellum, so that the vermis is missing basically. So it just looks like a separated cerebellum. Differential considerations should include arachnoid cyst, but identification of a splayed cerebellar hemispheres may help to confirm. So our next one is holoprosencephaly. Now, if you remember this from the facial chapter, it's because holoprosencephaly is usually associated with some facial defects, including proboscis, which is our little horn, nose horn, and also hypotelorism, which is really abnormally close eyes, or even cyclopia. So the range of abnormalities resulting from abnormal cleavage of the prosencephalon forebrain, associated with chromosomal anomalies in up to 50% of cases. Could be sporadic though. There's 3 forms. What I want you to know about the 3 forms is which one's the most severe, and that's alobar. The intermediate form is semilobar, and the mildest form is lobar, although all of these have very poor prognosis. So with alobar, which is the most severe, you're just going to have a single monoventricle brain. So you're not going to have any kind of separation. Your absence of a lot of parts of the brain. So this is what it looks like here. There's just a lot of black, and you'll see just a little bit of brain contents in the back. Here's another one. Holoprosencephaly is associated mostly with trisomy 13 if it comes to one of the most common chromosomal abnormalities. This is a very small hypotelorism is what it's showing here, those little eyes that are really close together. Here is a proboscis on 3D and very small eyes. This baby had holoprosencephaly, a lobar. So these are the different kinds of alobar holoprosencephaly you can have. You're not going to be tested on this. I just want you to know that this is the most severe form. Semilobar is not as severe, but yeah, it's still very severe, if that makes sense. It's single ventricle cavity still with partial formation of occipital horns. Rudimentary falx, interhemispheric fissure. So the falx is still not there. Absent corpus callosum, cavum septum pellucidum, absent olfactory bulbs. So on the left, the lobar is where still holoprosencephaly, still not a good prognosis, but not as bad as alobar. And one thing that why we want to look at the cavum septum pellucidum is in all of the holoprosencephalies, they will be absent. So on the left side, this is a normal brain. You can see the cerebellum just to the right of it. It's the thalamus. And then there's 3 little lines right here. That's part of, that helps you to show that the cavum septum pellucidum is there. You will not see that on lobar holoprosencephaly. The causes vary. Could be a chromosomal anomaly, just like I said, most specifically probably trisomy 13, but I have seen it with trisomy 18 and triploidy. Trisomy 13 is the one I want you to think of when you think of holoprosencephaly, though. rare instances, the use of oral contraceptive and aspirin during pregnancy could cause this, but that's very rare. The prognosis is uniformly poor. In most severe forms, the fetus dies at birth or shortly after. In least severe forms, survival is possible, but they will be severely, very, very low IQ. So the sono features is that common C-shaped ventricle, brain tissue with a horseshoe-shaped, absent corpus callosum, absent cavum septum pellucidum. Again, also holoprosencephaly is also associated with those facial defects that we've talked about. The proboscis, the close eyes. Here's another image. So the cyclopia with the proboscis is the one I've seen this last year. Sebocephaly, ethmocephaly, lateral facial cleft, midline facial clefts are pretty common with holoprosencephaly too. It's just what we talked about before. Okay, our next thing is agenesis of the corpus callosum. It aids in learning and memory. So if it's not there, it's kind of, the fetus is not going to function, or the baby is not going to be able to have as normal of IQ as it should. I want you to know that what I want you to know is that they may be asymptomatic or associated with mental retardation or seizures. But what we can see sonographically, because we really don't look too much at the corpus callosum, is the absence of the cavum septum pellucidum will hint us off that there's something wrong, and that there could be a potentially absent corpus callosum. The other thing is that we will also be able to see the lateral ventricles in a teardrop shaped, because the lateral ventricles will be dilated greater than 10 millimeters and have ventriculomegaly. So this is an enlarged lateral ventricle here. Here's the thalamus, and we're just not seeing those three little lines that are indicator that there's is a cavum septum. You won't need to know these. Please don't spend too much time on those. A little bit about aqueductal stenosis. It results from the obstruction, atresia, or stenosis of the aqueduct of the sylvius, and causes ventricular megaly. So everything just kind of gets obstructed, and so the fluid can't drain correctly. So it's going to cause ventricular megaly, maybe hydrocephalus. The prognosis is poor, and survivors have less than 70 IQ. That's all I really want you to know about that. So you're just going to add aqueductal stenosis is associated with ventricular megaly. The third ventricle will also be dilated. Could have flexion adduction of thumb if it's an X-linked form. There is a thing called a vein of Galen aneurysm. I'm not going to test you on that right now because it's very rare, but it's considered a sporadic event, male predominance, usually isolated anomaly, and there's going to be a lot of vascular flow within the brain, basically. The prognosis is generally poor. So you're going to see a cystic space, maybe irregular in shape, or located midline or posterior superior to the third ventricle, and it's just going to be very turbulent with Doppler evaluation. Now, I have not seen this, but it is very, very rare. What I really want you to know is, like, I'm trying to pick out the most ones that you're going to see, the ones that are going to be on your registry, the ones that you're going to have to know for everyday life when you get into it. And the choroid plexus is one of the ones that you will see a lot. And I want you to be able to identify these because it's important. So the round or ovoid anechoic structure is found within the choroid plexus, common, occurring with frequency of 0.4 to 3.6%. I see them more than I feel like 3%, but they contain cerebral spinal fluid and cellular debris trapped within the neuroepithelial folds. Usually is isolated finding with association with other anomalies. So it's usually okay, but you do need, it's a soft marker for trisomy 18, unless trisomy 21, which means it doesn't necessarily mean that the baby has trisomy 18 or 21, but it means it's associated with it. So if you see a choroid plexus cyst, you want to definitely still mention it. And if it's large enough, measure it, because the baby needs to be evaluated for trisomy 18 or come back and make sure it's resolved. Generally speaking, though, if you just see an isolated choroid plexus cyst and there's nothing else going on with the fetus, it's probably just an isolated choroid plexus cyst. So cysts within the choroid plexus range from 0.3 to 2 centimeters, unilateral or bilateral cyst, solitary or multiple, unilocular or multilocular, enlargement of ventricle with large cysts. So this is what it looks like. You're going to usually have your choroids that are nice and echogenic, and you're just going to see cysts within them. This baby had trisomy 18. If this happens and they might want to do an amniocentesis to see if the baby does have trisomy 18, but most of the times, if it's just an isolated choroid plexus cyst, they would not do this. So again, on your left side, I put a normal choroid plexus. You can see they're just echogenic, intact, no cyst. This is what you're going to see a lot, is you're going to see that choroid plexus, and you're going to see that black hole within it. This is the choroid plexus cyst. Hydranencephaly is the destruction of the cerebral hemispheres by occlusion of the ICA. You will need to know that. Brain parenchyma is destroyed because there's no blood flow to the brain, and replaced with cerebrospinal fluid. It's very rare, but yet I have seen it this year. May also be associated with polyhydramnios. It could have a chromosome anomaly. It could just be isolated finding. It's a very poor prognosis, though. Infections associated include cytomegalovirus and toxoplasmosis. That's why I say in your first trimester, don't do kitty litter. That is increased risk for toxoplasmosis. Don't change baby diapers without gloves on, because that can cause infants cause cytomegalovirus, and if you're exposed to CMV while you're in your first trimester, you have a higher chance of different things that could go wrong. So I have a list of things that I say don't do. Brain ischemia may result from maternal hypotension, twin-to-twin embolization, vascular agenesis, could be associated with cocaine abuse. The prognosis is grave. So the sono features is the absence of the normal brain tissue with almost complete replacement of cerebral spinal fluid. So you'll just see a black area where the brain should be. There won't be full falx separating the two hemispheres. So that's kind of what it looks like. It may be confused with severe hydrocephaly, although presence of intact falx and surrounding rim of brain parenchyma may help to differentiate. And holoprosencephaly with severe ventricular megaly may have similar appearance. So ventriculomegaly is another thing that you're going to see more often. Again, I saw this last week. And hydrocephalus is actually ventriculomegaly, but it's also coupled with there's so much fluid that the head is big. So hydrocephalus is enlargement of the fetal head with ventriculomegaly. The enlargement of the ventricles occur with obstruction of the cerebral spinal fluid flow, and the obstruction may be caused by a ventricular defect like aqueductal stenosis or a different central nervous system defect like spina bifida. It's just showing where it could be obstructed. Physiologically, when the obstruction occurs, ventricles dilate as flow of the cerebral spinal fluid is blocked, and it increases pressure within the ventricular system, which leads to ventricular expansion. So what I want you to really know is, what does it look like? These are horrible pictures from your book. I got better ones. Okay, so on your left side, this is where you would measure the lateral ventricle at the posterior horn. And you can see the choroid plexus is filling the lateral ventricle, so that is a normal lateral ventricle. And these two images, you see the choroid plexus cyst almost hang, and this is called the teardrop sign, which is a telltale sign of ventriculomegaly. And this measurement is definitely greater than 10 millimeters, which is our cutoff for normal. Here's the same thing, or a different baby that has ventriculomegaly, but then the choroid plexus looks so small compared to the lateral ventricle. Could be a manifestation of a syndrome or abnormality, also associated with toxoplasmosis and CMV. So be careful there. Typically progresses from the occipital horns into the temporal, then the frontal horns. And ventricle is considered dilated when it exceeds 10 millimeters. The mortality rate for fetal hydrocephalus is high. The outcome depends largely on the presence or severity of the associated anomalies. And the prognosis has improved in those with isolated ventriculomegaly. Survivors may require ventricular shunting to improve survival and intellectual outcome. So your sono findings are going to be the lateral ventricle enlargement greater than 10 millimeters, a dangling choroid plexus sign, possible dilatation of the third and fourth ventricle, and fetal head enlargement when the BPD and head circumference exceed those of established gestational age. Here's another of the lateral ventricles being dilated. Fetus should be surveyed for associated anomalies, which occurs about in 80% of the cases of ventriculomegaly. Cesarean delivery may be necessary due to the large head if there's hydrocephalus. So severe hydrocephaly may be confused with hydranencephaly or holoprosencephaly, but if you see a complete falx separating and the presence of the choroid plexus, you probably can just assume that it's hydrocephaly and ventriculomegaly. Microcephaly is an abnormally small head that falls 2 standard deviations below the mean, and it occurs because brain size reduced. Do you guys remember what was causing microcephaly, or what they thought it was? Zika virus from mosquitoes. In Brazil, there was a lot of babies that were getting microcephaly. Prognosis depends to a degree on the cause, but about 85% of children with microcephaly are mentally retarded. Sonographic diagnosis depends on accurate assessment of fetal age. So you want to make sure that you're measuring everything correctly. Impaired cranial growth should coincide with appropriate growth of abdominal circumference and femur length. Microcephaly may manifest later on in pregnancy, so the diagnosis before 24 weeks of gestation is impossible. Sono features is a small BPD, small head circumference, and abnormal head circumference to abdomen circumference and head circumference to femur length ratios. Small head. This baby also has mid-face hypoplasia. You can't really see the nose very well. It's not prominent. Other sono findings associated may include disorganized brain tissue and ventriculomegaly. Fetuses with encephalocele may have microcephaly because of the amount of brain tissue protruding outside the calvarium. You don't need to know this. Could be associated with the trisomies. Here's normal head, microcephaly, and severe microcephaly. There's a baby with it. All right, that's it. Have a good day.